Hi, Dr. Bertram. I'm Tyler Parker. I'm in your MFT 6102 class for psychopathology. Um, so I chose to do for the week number 4 assignment to do a clinical diagnosis of one of the diagnosable characters. So I did the Soloist, and I was wondering if maybe it would be possible to diagnose the other character, not just obviously the one who exhibits schizophrenia, but also Mr. Lopez, because he seems to be maybe a little bit narcissistic or self-centered at least. So anyhow, yeah, I watched the movie, and I guess I was struck most by I guess the schizophrenic behavior of the main character there. Okay. I'll start off with the first thing that you wanted us to do for diagnosis and supporting evidence. So I used the DSM-5 to come to the diagnosis that I chose, which was schizophrenia, go figure. But I also wanted to determine what it wasn't that he had. Just wanted to be sure that the diagnosis that I was giving would be accurate. So I happen to have, this is a really cool interview guide for evaluating DSM-5 psychiatric disorders in the mental status examination. So I looked in here. It's by Dr. Mark Zimmerman. I looked in here at the schizophrenia and other psychotic disorder section to see what differential diagnoses there would be. And so for these, there are schizophrenia, delusional disorder, brief psychotic disorder, schizophreniform disorder, schizoaffective disorder. And yeah, so those are pretty much the ones that I had to choose from based on, what I would think that the criteria would be trying to say. So he's not delusional because delusions, according to the DSM and the interview guide, mean that the things that he was imagining or thinking or whatever could potentially happen. Like he's being pursued by someone, or he owes someone money and they're trying to kill him or something like that. Being persecuted, things like that. But the things he was imagining weren't necessarily realistic. He was imagining that, Mr. Lopez was flying the plane while at the same time standing right next to him, or imagining that Mr. Lopez was God, which he isn't. So I definitely think that he's having some schizophrenic thoughts as opposed to delusional thoughts. I also didn't think that he had schizophreniform disorder because his symptoms lasted for longer than 6 months, and that would be basically like the main criteria to separate schizophrenia from schizophreniform disorder. Also, he didn't seem to have schizoaffective disorder because he didn't have extremely manic episodes or bipolar episodes, or however you want to say that. So pretty much everything boiled down to schizophrenia. So the criteria that the DSM-5 lists that he has to fulfill. So diagnostic criteria for 295.90. So criterion A, 2 or more of the following, each present for a significant portion of time during a 1-month period or less if successfully treated. At least one of these has to be 1, 2, or 3. So delusions. I wouldn't say that he's necessarily delusional, so I'd say no to that. Hallucinations, definitely. Visual and auditory hallucinations. But it seemed to be, though, that when he had his initial onset, I guess what they would call the prodromal stage, and leading up to the acute stages of his illness, he knew what was going on. He knew that he was having trouble, especially when he talked to his mom on the phone. And he had really active hallucinations of voices and, seeing things, and, it was just really a wreck. So, yeah, I would definitely classify that as hallucinations. Disorganized speech. Okay, here's a sticky one. So, yeah, some of the things he said were, I guess, disorganized, you could say. But on the whole, the metaphors of the things that he was talking about, I didn't necessarily think were absolutely insane, because they were still somewhat grounded in reality. And I think that for me as a clinician in the future, that's going to be one of the things that I have trouble with, because, I can make those connections to the things that they're saying, and in a way they make sense in a very, very, very roundabout way. But I wouldn't say that they're just completely left field, like they don't make any sense at all. So maybe that was just a character portrayal, or what have you. But I didn't think that they were so far out that it's like word salad. I wouldn't say that he exhibited word salad. The metaphors he were using were pretty creative. Okay, some of the things are a little bit out there, but on the whole, I think that he kind of had it together a little bit. Grossly disorganized or catatonic behavior. I wouldn't say so. No. Negative symptoms, diminished emotional expression or avolition. So I did notice that he did have a bit of that. I didn't really see him laugh at all. He did get upset at times. But on the whole, he did seem to have diminished affect. So I found an article, diminished emotion expressivity, but not experience in men and women with schizophrenia. So basically what it's saying is that men and women with schizophrenia have diminished emotional expression, though they do still experience emotions, pretty much the same as other people. So it's just that their faces don't necessarily respond. Their affect is a bit flat. So, he did have that, and, I guess that's to be expected with the diagnosis. So I would say, yeah, he does have negative symptoms. So criterion B, for a significant portion of the time since the onset of disturbance, level of functioning in one or more major areas such as work, interpersonal relations, or self-care is markedly below the level achieved prior to onset. Definitely. So he was able to, care for himself, groom himself properly, manage with the day-to-day stresses of life, and not have a complete breakdown, or, be broken by his hallucinations. So yeah, there definitely was a marked difference between when the disturbances occurred and what he was functioning as before the disturbance onset. So yeah, I would say criterion B is satisfied. Criterion C, continuous signs of the disturbance present for at least 6 months or persist for at least 6 months. A 6-month period must include at least 1 month of symptoms or less if successfully treated. That meet criterion A. And may include periods of prodromal or residual symptoms. During these prodromal or residual periods, the signs of the disturbance may be manifested by only negative symptoms or by 2 more symptoms listed in criterion A, present in attenuated form. Yeah, so they definitely persisted for longer than 6 months. They were his, I would say it's a chronic condition, and it did have the correct time of onset, which is before the age of 25. Because he went to the Juilliard school, so I'm assuming that means that he was in high school. I think that's a high school. So, yeah, he meets that criteria. Schizoaffective disorder and depressive or bipolar disorder with psychotic features has been ruled out because, 1, no major depressive or manic episodes occur concurrently with the active phase symptoms, or 2, if mood episodes occur during active phase symptoms, they have been present for a minority of the total duration of the active and residual periods of the illness. So like I said at the beginning, schizoaffective disorder has been ruled out because it's not, he doesn't have the affective disturbances through the entire period of his schizophrenic hallucinations, delusions, what have you. The times where he does exhibit what might be considered schizoaffective, and his affected emotional tone and expression are less than, 10% or so. That's what Dr. Zimmerman outlines is, I think it's 10 to 20%. He says if you have schizoaffective functioning less than the time that you are expressing the other symptoms, the more positive, I guess, the more florid symptoms of schizophrenia, then you would rule out schizoaffective disorder. Once it reaches, the majority of the time, then you would say that a person does have that. And I also wouldn't necessarily say that he's depressed. He doesn't say that he wants to kill himself constantly. He's still able to get up and move and do things. I would think more than anything, he's probably has a bit of anxiety, which the DSM goes into for that too. But that's later on when you get into, I want to say differential diagnosis, but I don't remember right now. I can't find it. But yeah, you sometimes you would see anxiety along with schizophrenia. The disturbance is not attributable to the physiological effects of a substance or another medical condition. He doesn't have any other known medical conditions, but Dr. Zimmerman does outline for the clinical interview to go over a physical exam and family history and substance use history, just to ensure that the patient or the client or what have you is not suffering from the effects of one of those conditions. So ruling that out, hypothetically, he doesn't fall into that category. Criterion F, if there's a history of autism spectrum disorder or a communication disorder of childhood onset, the additional diagnosis schizophrenia is made only if prominent delusions or hallucinations in addition to the other required symptoms of schizophrenia are also present for at least 1 month. I kind of was thinking at the very beginning that he might have some autism spectrum symptoms, but I don't think he probably satisfies enough criteria in order to be classified as such. I mean, he does interact with other people. He does, want to be around other people. He finds other people interesting. I don't think that someone on the autism spectrum would necessarily latch onto so much another person like he did to Mr. Lopez. And additionally, Beethoven is a person. But I guess that would, if Beethoven to him was more of an idea or a symbol, then maybe you could say that he would latch onto him if he was ASD, but I didn't want to go down that direction. I don't think that's necessarily relevant or accurate. So yeah, those are the ways that I'm going to support my diagnosis. There's a rule-out diagnosis. Please highlight the way in which the client does not fit the rule-out. Okay, yeah, I already pretty much covered that stuff when I talked about ruling out schizoaffective disorder. And the other sorts of disorders for the differential diagnosis. Yeah, so differential diagnosis, major depressive, bipolar, psychotic or catatonic features. He doesn't have that. Schizophreniform, no, because it's too long. Delusional, those aren't delusions. Schizotypal disorder. I looked into that with the diagnostic interview stuff, but he doesn't have the schizotypal social functioning that would go along with having schizotypal personality disorder. OCD, body dysmorphic, no. Post-traumatic stress disorder, that's unknown. Autism spectrum disorder or communication disorder, no, I don't think so either. Other mental disorders associated with the psychotic episode, I don't know. I don't think so. Okay, so that covers that. Description of the disorder. In addition to criterion cited in DSM-5, find 2 scholarly articles or online resources or other information to help you better understand the disorder and select your diagnosis. Using these articles as a reference, describe the nature, etiology, course, and effects of the disorder. Be sure to discuss the systemic effects as well as the effects on the individual. Okay, so like I said, I found the article on the diminished emotional expressivity of those with schizophrenia, and so it's now something that I know to look for, and not necessarily to think that the person is depressed because they have diminished emotional expressivity. I'm gonna work on that. So yeah, I think that's just gonna make me more accurate with my diagnosis. The other, I don't know if you'd necessarily call it an article, but I picked this up, a while ago when I first ordered the DSM-5, around the time that it came out, and it's been really helpful in all of my classes to sort of get an understanding of the types of things that I would be asking someone in order to come to a specific, diagnosis, one or the other. So it's definitely a good tool. So yeah, okay, the nature of schizophrenia. A lot of people have an idea about what it is. The DSM is pretty specific on what it says as far as diagnostic features. It talks about the different criteria. So it's really up to the clinician to, figure out and tease out how the criteria are expressed with the symptomatology of the client. It doesn't really tell you what kinds of things you would say, but I guess they just rely on the reasonable man standard or reasonable person standard. So yeah, schizophrenia also involves impairment or one or more major areas of functioning. So, he lives on the street, he's homeless, he doesn't have a job, he doesn't want to live in a house. Well, but at the same time too, I think that being a clinician, you have to understand why someone doesn't want to be in a certain situation. I think that that's what marriage and family therapists really try and do. They try and dig into the why rather than, just label, and hope that does something for someone. So he didn't want to be in an apartment, obviously, because of what had happened last time he was in an apartment by himself. He lost his mind against his will. So, it really, to me, it makes sense that he wouldn't want to be in an apartment. He'd want to, be out in the world where everything is open and he doesn't have to feel afraid, because when he went to the apartment, he was talking about someone's going to come inside and kill me, and where am I going to go? And I remember what that was like, being in a studio apartment, especially when you don't have anywhere to escape out the back if someone were to come inside. And I have had someone come inside before, but they weren't trying to beat me. They were beating someone else inside my apartment, but I couldn't run. And when the person came back, I had nowhere to go. So for me, I can understand that. I can definitely understand that. So, yeah, he also doesn't really have a whole lot of social supports. He doesn't have any friends, it seems like. So he's definitely, I would say, probably lacking in the social aspect. Okay, they also have to persist for at least 6 months. So that rules out schizophreniform. Mood symptoms and full mood episodes are common in schizophrenia and may be concurrent with active phase symptomatology. I wouldn't necessarily think so. I think that he was reacting pretty normally to the situations that were ongoing with where he was. Yeah, so that's the diagnostic criteria. And also, well, that would also be, I guess, the nature. But yeah, a little bit more about the nature. So you also have a lot of disorganized speech, thoughts. The things that you say might make sense, but in a very roundabout way. It's very metaphorical. It's like you can't stop living inside of the poetry that you've created for yourself. If words sound similar and they have even the weakest link, they're expressed, and you just go off on tangents, and you're not as accurate with the thoughts that you're trying to convey as you should be to be considered a normal person. You kind of touch and dance on a specific subject, and then you move on to the next thing that you're reminded of. So yeah, it's definitely a thought disorder. It keeps you skipping along in your thoughts pretty dramatically. Yeah, etiology. So there's not really like a blood test that you could do for it. You could get it if you do a lot of drugs and you have a really bad reaction to it. But people, I have heard that there's like, oh God, I don't know what you would call it, but basically it's an onset due to substance abuse, which is in one of the criterion. I forget which one it is. Yeah, criterion E. Yeah, so you can definitely attribute that to like speed, meth, sometimes cannabis, if it's laced with something, really, really terrible. Um, they say that there are some genetic predispositions to it if you have it in your family, but that doesn't necessarily mean that you're gonna get it. It just means that it's a little bit more likely. So yeah, etiology is just kind of crazy, because you have your positive symptoms, you have your negative symptoms, but they're all categorized in the same sort of spectrum, I guess you would say, a bit like autism. So etiology is just kind of, I don't know, it's kind of broad. I couldn't really say specifically like this specific thing causes schizophrenia. I don't think that anyone can at this point. So course, yeah, the course is chronic. You have prodromal symptoms, and then you have your active phase symptoms, and then you have your residual phase symptoms. So during your prodromal phase, you might, think that something is going wrong, or you're starting to have lead up scattered thoughts, but you still have 1 foot in the sane world and 1 foot in the insane world. But once you progress past the prodromal phase, and you're active, you might not even know, or the client or whoever, the family, might not even, the family would know, the client wouldn't, sometimes, that they even have schizophrenia. And that was really the problem for Nathaniel in the movie, because he didn't really think that he was schizophrenic. It never really got brought up until he read the legal documents at the end of the movie. And because he had such poor insight, his outlook is also really bad. And that also goes along with the diminished emotional expressivity article, where they say that if the client doesn't know that they have diminished expression, then sometimes feedback about their expression isn't as helpful as if someone knew that they did have diminished expression. So that's sort of the active phase. That's where, people get the ideas about the crazy man on the street. He's out in the middle of the street. He's wearing an aluminum foil friggin' jacket. He's dressed crazy, like with an American flag thing on his head and, the white paint on his face. Yeah, that's active schizophrenia. That's what it looks like. That it's the crazy guy in the middle of the street, but at the same time, he did have his soothing activity, which was playing a musical instrument. So, I think that the soothing activities definitely tampened down a lot of the active phase symptoms, which was really, good for him. It's really, it's great that he had that, because if he didn't have that, it would probably just be active phase uninterrupted throughout his entire life. Yeah, and then you have your residual phase, where obviously it's, kind of dying down a little bit, not as floored, I guess, as the active phase is. Yeah, and it's supposed to be chronic, but I guess it depends on the etiology, how the course runs. If I've read that if an individual develops schizophrenia earlier in their life, like childhood, their prognosis is pretty bad, and usually they don't recover. But those who have more acute onsets sometimes have the best recovery, because it arises so quickly, and it peaks out, and it plateaus, and then it dies out. So, the slower the onset, I guess the slower the onset, the worse. The earlier the onset, the worse. And that's pretty much what it comes down to. Okay, and the effects of disorder. Yeah, so I talked about the effects a lot. I'm pretty sure that was covered pretty well. Okay, so I only really talked about the effects on the individual, but there's also systemic effects that, the DSM doesn't necessarily cover so much. And you can see from the movie that it affects his family greatly. He had to go live with his sister, and he was living on his own, and his sister tried to help him out, but he ran away. And she really didn't know what to do. He ran away. He became homeless. But, she never really forgot about him. She had a tender spot for him, all the way up until when Mr. Lopez called. So, having a family member with schizophrenia can be just as scary for the person going through it as it is for the family, because, no one is really sure what's going to happen, what to do, what to think is correct when the person is talking, like who they are. And so, their position in the family is really shifted in a very dramatic way. And so, getting the family to see each other as a cohesive unit like they were before, or, just a family unit at all. It's like the person that they used to know has been substituted by this person that they no longer know. And that's really difficult because they look the same. Their face is the same. They have the same name, the same histories together. But, once schizophrenia takes over that family member, they aren't really seen as that family member anymore. And I think that was probably what happened until the end of the movie, where Jennifer came back and she saw her brother, and she wanted to, be the executor of all his, things that mattered to him legally. She wanted to reintegrate with that family unit that she had lost because of the disease. And so, they united through his, I wouldn't say his success in music, but I would say his success in becoming human again, his success in being validated. Because, prior to that, no one was reporting on him. He was just a crazy man on the street. But when his existence was validated, it was easier for his sister to see him as a person that he used to be. Well, not used to be entirely, but that could be a part of her family system, that she could care about and she could reach out to, and she could actually do something to help. So yeah, I would say that's a general idea about the systemic effects. But I'll go into the treatment plan, because that deals a lot more with the treatment effects. The systemic effects. So develop a treatment plan for working with a client using a family therapy-based treatment. Identify a specific model you would feel would be beneficial for these in this case, and then do each of the following. So, okay. I'm a big fan of symbolic experiential family therapy. Huge fan. Because I'm a huge metaphor kind of person. I'm a huge symbol interactionist kind of person. I think that those are the ways in which we conceive of reality, symbol systems, and ways that we interact with words. So, learning about symbolic experiential family therapy, and I believe it's the Carl Whitaker, The Family Crucible. Reading that, I was like, this is it. This is exactly what I think too. Like, this is great. But also I was struck by Michael White's narrative therapy. And so what I did for one of my other classes was come up with a way to sort of put the two together into a model of my own, which was, okay, is this the right assignment? Yes. Yeah, so, to use the narrative therapy approach along with the symbolic experiential therapy approach to help the family unit work with the symbol systems that they've created and respond to each other with. I think that would probably be pretty powerful, though I haven't, read any research articles on it yet, and working with schizophrenic patients, because that is the world that they live in. The world that they live in is constructed of interacting with symbols that are inside their head that no one else agrees with or even understands or know exists, because they make them up as they go along. And what I think that the counselor, the therapist at the LAMP community center was really getting at was that, a diagnosis isn't really helpful to these people. What they really need is just to be validated in the ways that they see themselves and they see the world and they see each other. He was just there to listen to them, to guide, not really guide them, but provide a cushion for them to figure themselves out. Because I think that the one big thing that Mr. Lopez did that he really shouldn't have done was he didn't let Nathaniel lead. He didn't. He decided to do everything for himself. He took his problems and his directions under his own charge, which you can't do, especially as a marriage and family therapist. Like, your job is not to grab people by the collar and lead them to the solution that you think is the best for them. Your job is to gently guide them along. It's like playing bowling with bumpers on the side. You're just the bumpers. You want them, obviously, to get a strike or at least to spare, but you're there so that they don't, necessarily fall into the gutters as it will. So yeah, but obviously he wasn't a psychotherapist. He's a news reporter, and he was just trying to get a story. So, right. So you have obviously the initial phase, the middle phase, and the late phase goals of a treatment plan. So first, you want to develop a working therapeutic relationship. What I had from my previous work and what I would still use here. Use therapist's authentic self in meeting the family members apart from the problem. Inquiring about identities outside of the problem. In doing so, engage in mutual relationships that stokes growth in everyone. Okay, so use therapist's authentic self in meeting the family members apart from the problem. He doesn't know he has schizophrenia, but he knows that he's different. He knows that he's homeless. Jennifer knows that too. So I would just meet with them where they are. Let them explain where they are and just be there with them. Explain who I am and where I am, but also where we are together. Not necessarily, blocked by this specific problem, but in the initial phase, the whole idea is just to meet with the family, to sit down with the family, to be with them. Inquiring about identities outside of the problem. Ask them who they are, Jennifer, who are you? How do you describe yourself? And the same thing with Nathaniel. Who are you? Like, how would you describe yourself? You hear voices sometimes. You live on the street. Those are circumstances. That's not a self-description. So I'd like to hear your self-description. So, yeah. Engage couple family from hopeful, optimistic position as a co-author of new narratives to include new metaphors and experiences. This is what I would be specifically really, really excited about. So what you can do in family therapy is, especially this approach, is to hear what the metaphors and the symbol systems are that they use to define themselves or define their positions, and very creatively, very craftily sort of use those same metaphors and symbol systems to redefine who they are in a more positive context. So, like, I guess you'd say, like, the proverbial light in the tunnel or whatever, like someone's saying that they're in a dark tunnel, and, this is very vague in general and not very creative at all, but, the light at the end of the tunnel is not an oncoming train. My dad used to say that all the time. So, yeah, you really need to help them redefine and co-create new narratives to live by, to redefine themselves in a way that they're actually proud of, that are accurate too, that aren't just a bunch of psychotherapy gobbledygook. Assess individual systemic and broader cultural dynamics. Ask relative influence questioning to map the effects of conflict and the effects of persons on conflict. I'm sorry, I can't read that. On the conflict, so ask relative influence questioning to map effects of persons on. So just to ask them, like, how the problem is affecting them and how it creates conflict between the two of them. So obviously Jennifer wants what's best for her brother. Nathaniel pretty much wants to do his own thing, live freely on the street. He would rather do that. And that can cause a conflict or a conflict of interest. And that's where the reorganizing the narrative becomes very tricky, because you have to well, the next block 3, define goals of what they want. And if their goals are separate, it's going to be really hard to bring them together. So identify unique outcomes, assess how emotional processes and family dynamics contribute to this conflict mapping. So conflict mapping is pretty much just to say, like this happens and this happens and this happens, and this is kind of, how things play out, just to have the narrative of it. So during the assessment phase, you want to figure out how the conflicts are coming about. Identify the dominant discourses that support conflict and the local alternative discourses that may be a resource for changing relationships to conflict. This is pretty huge in narrative therapy because when you have a family unit and they talk about how they argue so much or certain fights always happen, you've got to find those parts when it didn't happen that way and it happened a different way. Like, they had a problem, and instead of arguing in the way that they always do, this time they actually listened to one another and they got the outcome that they wanted. That is a huge tool for, reinforcing that, you don't have to fight all the time. You can do that one thing. You did that one time instead. Define and obtain couple agreement on treatment goals. So obviously it would be family instead of couple. So identify the family's preferred relational and identity narratives. How would they like to be defined? How would they like to define their relationship? Emphasize and encourage goals that promote personal growth, increase family cohesion, and expand their symbolic world. Note if resistance is encountered in this treatment task, ease away and revert back to the client's preferred narrative. The tasks are theoretically in conflict to begin with. So again, with the metaphoric and symbolic ways of being, of living, of seeing, your job or my job would be as a prospective therapist to help them find more workable symbol systems, to not see the other person as a devil that they have to avoid, to see the other person as more of a human being defined in more realistic terms, that doesn't demonize or make the problem look like it's bigger than they can overcome. And if, like I said, if you encounter resistance with that, then you sort of have to take steps back to meet them back where they are before you can help them forward again. So number 4, identify needs, referrals, crisis issues, collateral contacts, and other client needs. Yeah, that's pretty self-explanatory. Nathaniel needs a lot. Housing, if that's what he wants, one of them, food, clothing, a shower, a shave, money, all those sorts of things he needs, and he needs them what we would think pretty desperately, but he doesn't see it that way. He thinks that he's perfectly well off just the way that he is, and he's happy with that. He's not asking to change. He doesn't ask to change the entire film, except at the beginning, of course. Okay, so initial phase client goals. Increase tolerance for and expression of authentic emotion to reduce relational conflict. Yeah, so, him and Jennifer don't really fight outwardly so much. It looks like Jennifer's very, very, very accommodating. So I wouldn't say that they had a lot of relational conflict. I think that the conflict would be with the goals that they have for one another. So when those things come up, and of course they're going to come up, and there's paperwork that he needed to sign that express different goals, how to talk through those without getting angry, I think is important. I think that that's their biggest conflict, is what she wants for him versus what he wants for himself. Avoid externalizing the problem and encourage working out the conflict as it is. Okay, so here's where the big break with symbolic therapy and narrative therapy is. Michael White would prefer that people externalize their issues and then talk about them as if they were a monster that they need to attack. Carl Whitaker, on the other hand, kind of works within that conflict and the symbol systems of that conflict to overcome that conflict. So I have to side with Whitaker on this one. I'm don't really think that it's a good idea to take a problem outside of yourself, because then it's not something that you're working on inside of yourself. It's something that's outside of you. And I'm a really big internal locus of control kind of person. So for me, that's what I would want to direct for my clients. I wouldn't want them to see their problems as outside themselves, because then they don't have to take any responsibility for what happens. All right, use of play and craziness to invite couple into present a moment and experience of authentic emotions. I think that if me as the psychotherapist and Jennifer would experience the craziness of what Nathaniel was saying and really try and make sense of it and the way that he makes sense of it, I think especially for her, that would be really beneficial to her understanding him, because I get it. I've been there. Like, I know what that's like, and that makes sense to me. So it's hard for me to say that what he's saying doesn't make any sense, because it does make sense, except for the whole flying in the airplane thing and Mr. Lopez being God. That I don't really necessarily think is crazy. But just, when he talks about caring for the violin, you can't bash it up against the wall. When he goes on his, little rants about what he thinks, some of that makes sense. It's logical in a metaphoric sense. And so, I can't say that that's too crazy. Redefining and expanding symptoms as ineffective attempts at growth and identify alternative directions. That is particular to, I guess, I don't know how you would say it, but the anti-diagnosing worldviews of early marriage and family therapists, but he clearly does have some medical issues or psychological issues, so I'm going to go ahead and say that that's not going to be a part of this one. Invite the family to re-author their perceptions as well. They're more than welcome to redefine their relationships, and I definitely think that they should, but I don't think that they should stray away from the diagnosis. It's pretty accurate. He just has very, very poor insight to it, which is another manifestation of schizophrenia. Sometimes you don't even know you're crazy. If you do, you're a lot better off. Ignorance is not always bliss. Working phase therapeutic goals. I know I'm probably running pretty close on time. I'm probably over already, so I'll try and go through this as quickly as possible. Monitor quality of the working alliance. So, of course, as you're going through, you want to self-assess and make sure what you're providing to the patients, or to the clients, rather, is working, that you're actually together, that you're not working on separate goals. Assessment intervention. Monitor couple family response to therapist's authentic use of self and regularly discuss. Ask Nathaniel how he's doing, like how he views the relationship. Is this relationship good for him? Does he like it? Does he hate coming to see me every day? Or is it something that he looks forward to? Same thing with Jennifer, just check in with her, at the end of every session, see how the treatment, how she feels about the treatment and what's going on. Monitor client progress. Assessment intervention. Monitor for clients' experiences and authentic self in and out of session. So basically, make sure Nathaniel's being real to himself. When he leaves the office, he doesn't have to be the person, that he feels that other people want him to be. Like, no, be who you are, because the goal is to make who you are better for not only yourself, but for your family system. And better is subjective. Monitor sessions for evidence of client generating new meanings that translate to new actions. Huge. Because if he's already using metaphors, so if he can use those metaphors in a way that makes him better, makes him more well or better functioning, he'll probably never get over the schizophrenia, but he can live a life that is not a tragedy. And at the end of the movie, he is doing better. His living situation is better. Psychological situation is still the same, but at least he's in a better living situation. And so, using the recovery model of psychotherapy, like, you're probably always going to be sick, so you got to do the best that you can with the sickness. So, working phase client goals: reduce rigid relational patterns, clarify boundaries, and increase role flexibility to reduce conflict. This is what I think that they need more than anything. The relational pattern that was established with the paperwork by the hands of Mr. Lopez was that Jennifer would be in charge of him. Obviously, he's an independent man. He almost killed Mr. Lopez to make that point. He needs to be independent. Clarify boundaries. He's already clarified the boundaries. I don't think boundaries really need to be clarified anymore. An increased role flexibility to reduce conflict. So, not only is he an independent person, but he can also use the help of his family to get better, to have a better living situation. So it doesn't always have to be just strictly independence. He can also rely on other people for help. These are seen to be the causal agents of the dominant problematic discourse. All right, got it. Affective confrontation of rigid pattern using humor, stories, and direct confrontation. So as the confrontations come up, especially about independence, try and make a metaphoric joke about it, or use the symbol systems that they already have in place to play with it a little bit and make it a little bit less stressful. Augment despair and amplify deviation by exaggerating rigid patterns to the point of absurdity. That's a really I don't know how he'd say Whittakerian approach, but that's what he does. He basically makes the family act out to the point where they would be patently absurd in the situation that they're in. I don't know. You'd have to be really creative in how you use the confrontation and just escalate it to the point where it's absolutely absurd and it wouldn't happen. It doesn't need to be there anymore, and then they realize that. But that's, I guess, where the art of therapy comes in. Map conflict versus unique outcomes landscapes of action and consciousness to strengthen alternative identities. So when you have a conflict, it doesn't always have to come out a certain way. You use the alternative outcomes of different conflicts to show the family it doesn't always have to be like this. Because remember that one time you guys fought about the same thing and you guys agreed and didn't fight? Let's do more of that. I guess that's the way that you can summarize that. Increase capacity to tolerate difference and conflict within the system to reduce conflict. So conflicts are going to happen. Jennifer's going to want one thing, Nathaniel's going to want something else, but you have to work with the family to see that, conflict is going to happen, but let's just reduce the emotional firestorm. It doesn't need to be like that. You guys are going to have conflict, but you need to just chill out. Here now experiencing of conflict and difference to reduce fears related to conflict. That might be a little bit different. A little bit difficult though, especially with someone with schizophrenia, because the fears and the conflict take on a different sort of atmosphere, a different sort of tone. They can be very vicious. They can be very consuming. And so you really have to watch out for that. You can't just, dive into that, be there, and then say, let's grow from that, because that can be pretty devastating. Playing craziness that exaggerates fear of conflict and rejection. I think that the more that you join with Nathaniel, the easier it would be to play with the crazy symbol systems that he has, especially if you can understand them. And use them with him. He might really enjoy that, and he might actually laugh. I don't think he really laughed in that whole movie. And I think that that's what he needs. There was an interesting quote at the end of the movie. It said something like, friendship can change the neurochemistry of a man, or something like that. It's just that openness and that vulnerability and that closeness, and that's, the it's okay to say that. It's okay to be mad sometimes, that people need to be accepted. Increase actions that support preferred relational identities to reduce conflicts. So, like I said before, do more of what works. Do more of what is good for the two in this situation. Utilize lessons learned from playing crazy scenarios. Discuss actions that can replicate the successes of therapeutic experiences and avoid therapeutic failures. So through the symbol system play, you can sort of help a family see that the problem, you can grow from it, when you act out conflicts in a way that actually works to show them, like, this is concrete evidence that you guys have this fight, but you did it a little bit differently this time, and it worked out. Um, Increase the breadth and flexibility of couples' symbolic world to reduce conflict by expanding possibilities for relating. So that would, with the major point of contention between Nathaniel and actually Mr. Lopez and Jennifer, that Nathaniel needs to be in a house like normal people and do normal people things like everybody else does every day. That's kind of their symbol system, like normalcy. Nathaniel's is an open world where there are no walls behind him, except, when he's sleeping, because he likes to sleep up against the wall. And, who would blame him? If you live out in the open, you don't want somebody to come up behind you. But, to sort of like make their two symbol systems able to live in each other. So that would be something that, a therapist would have to sit down and figure out, like, okay, Nathaniel wants to live outside. They wanted to live inside. How can you possibly have the two? Like, how would you co-create a meaning that makes sense for both of them, that one person doesn't have power over the other? So that would be a challenge. Absurd fantasy alternatives to help expand couple worldview, like entertain the idea of Jennifer living outside with Nathaniel for a week, and then the next week he lives inside with her, and then they just bounce back and forth. Like, what would that be like for them? You can use an imagination instead of having to actually do those things to help them, see through the process of, if we change this behavior, what do we think the outcome would be? And as they co-create that, they're working together, building an alliance between one another, and finding ways to talk through conflict, using their words rather than, running away or, being crazy or even hitting. Stories for association and metaphors to expand the sense of possibilities. That's like strictly what Whitaker does. Like, he's an artist at that, and everybody knows that. But I think that that's something that a therapist can do too, by, telling stories about using their symbol systems, different ways that they could do things right. So closing phase therapeutic tasks, develop aftercare plan and maintain gains, challenges and fears of relapse and happy ever after hopes, and identify playful options to responding to relapse. He's probably not going to be cured of schizophrenia. He might take medicine if he chooses to, if he's not a danger to anyone else, but he's probably going to be that way forever, so everyone should expect that. But we can make that living with the disease a lot easier. Map potential setbacks and landscapes of action and consciousness, and identify alternative behaviors and address potential blame. So potential setbacks, he's probably going to live on the street. I mean, that's just the way it's going to be. It's probably, actually, no. He was in his apartment at the end, but he might relapse while he's in there and end up back on the street. So we should definitely talk about that as an option. Jennifer might not like that very much. Nathaniel might feel like a failure. So that's something that needs to be addressed. So if that happens, what can we do different? Closing phase client goals, increase and thicken narrative of preferred family identity to reduce conflict and increase relational satisfaction. So, like I've been talking about the whole time, redefining that relationship so that they can work with each other with a new co-created symbol system that includes living outside and living inside, or being okay with living outside and living inside. And Jennifer helps him with stuff, but it doesn't mean that he's not independent. So, broadening that perspective of what's okay, that scope of what's okay, is really going to help them to see that the situation that they can create together is something that's actually not a bad deal for both of them. Map unique outcomes and landscape of action and consciousness to solidify new narrative. So, the unique outcomes, like the different things that are going to happen. Like, if they do this, then this is going to be different, and that's okay because A, B, C, and D. Increase family cohesion and authentic expression of self within the system to reduce conflict and increase sense of well-being. I've already covered that quite a bit. Separate personal from interpersonal distress to help client relate more authentically. Yeah, so Nathaniel's going to have some problems. Jennifer's going to have her own set of problems. But that doesn't mean that they have a problem with each other. And that should very clearly be stated. Confront fears of intimacy, worthiness, and rejection to enable clients to relate more authentically. Basically, help them have a better relationship. Increase ability to experience and tolerate present moment emotions and authentically express them to reduce depression and anxiety when they occur without reinstituting old narratives. Basically growing. When Nathaniel feels anxious about something, about the violin or the cello or whatever instrument it is that he's feeling anxious about not having or something going to happen to it, you have to play through those crazy scenarios, where the cello, maybe tells Nathaniel that he doesn't want to be with him anymore, and maybe they break up. What is Nathaniel going to do? Is he going to sit around and cry about it? Or is he going to go find a new instrument? Does the cello really have that much power in the relationship? Things like that. And, building that resiliency when situations go wrong is really going to help him deal with the other issues that he's bound to have. Here now experiencing about positive and negative emotions. Because those, they're not bad. Sometimes they're not good. They're not bad, but they just are. I guess that's more of like a mindfulness tip or kind of flavor to that statement. Introduce client-initiated play and creativity into daily life activities. I think Nathaniel's got quite a bit of that, but I think that he could do a little bit more. I think that he can learn how to, play with the symbols that he has in a way that doesn't create anxiety for him, in a way that he can, sort of self-talk and soothe his way out of feeling anxious or angry or running away and, like holding up a freaking bat with nails in it or 2x4 with nails in it at people. You know what I mean? Like, there's other ways to manage that anxiety and that stress of different situations. And that's what the whole goal of therapy is to do. You solidify those behaviors that you're going to take in the future when you get into a familiar situation that makes you uncomfortable, and you do it in a safe place so that whenever you leave, you can do it. You can be a little bit better. You don't have to swing on people. Host definitional ceremony to expand network of friends, family, and or school personnel who support clients' identities. So I guess that's like a little personal touch that Whitaker has, burying the hatchet, like literally going out and burying the hatchet that has the family's problems etched into it or something like that. But, a definitional ceremony would probably include some sort of instrument. It'd probably include Jennifer, playing a little duet with Nathaniel, or Nathaniel doing something that Jennifer wants to do. Maybe he'll sing and they can sing a song together. Who knows? Bring in a narrative reflecting team to support a couple and newly enacted identity. So you don't need to do that. Really, that's more of like a narrative therapy thing where people come in after the therapy session and they reflect on, what really struck them during the session. If you have a treatment team, sure. I mean, you can. But I don't necessarily think that it's like super, super critical. Because, the three people in this instance, myself, Nathaniel, and Jennifer, I think can all do that with each other. Okay, I'm sorry. Discuss at least 2 specific interventions that you'd use from this model. I already discussed all that. Discussed the relevance of the model for the case. Like I said, schizophrenics are typically very symbol-oriented, so I think that working with the symbols that they create in a very therapeutic way is entirely relevant. I also think that a narrative approach is relevant to that because they use their symbols to create narratives. So not only is it just like because the names are exactly what it does, but because the systems itself, like working with emotions and symbol systems, makes sense. Redefining the narratives that they tell themselves makes sense. So that's why I would think that those would make sense. Describe how using the family therapy-based treatment would be beneficial to the client in any ways. That additional services or referrals might be necessary. Yeah, I already covered all that stuff. In your description of the treatment plan, please be sure to continue to integrate information about the case from the film that you chose. Do not simply discuss what you do with the person. Write about how the model, the interventions that you selected. Okay, do not simply provide a synopsis. Okay. Yeah, let's see. Did I do everything? Copy the video. Okay, so yeah, I'm sorry. I really apologize for the length. I don't have a time or anything. But yeah, that about wraps it up. Like I said, I'm going to the ship next week, so I already printed out my required reading, so I'll try and see what I can do. I don't think I'll be able to take the quiz. I'm probably going to be overdue on that, but wish me luck, I guess. And if you need any more information, try to email me. We don't have computers, that's what they said, but you never know. We might. But I hope I got everything. Yeah, so I appreciate the time. Thanks.